So the first question, a person fainted while working in summer heat for a long time.
Mm-hmm.
Complaints are thirst, dry mouth, weakness, and oliguria. Physical examination, decreased skin turgor. Blood pressure is 110 to 70 millimeter mercury. Laboratory parameters are serum sodium is 152 millimole per liter, and serum potassium is 5. Hematocrit is 0.45. Hemoglobin is 160 gram per liter, and mean corpuscular volume is 70 femtoliters, which is smaller than average, which should be 95.
No, let's look what this patient has. All right. So this, yes, so this patient.
Hello?
Professor, we can't hear you.
Hello?
Oh, shoot. No, can you hear me? No, you can.
Yes.
Oh, okay, I'm sorry. I don't know what happened with my microphone. All right.
It's okay.
So what happened with this patient? So this patient was working on the heat and he did not drink at all. Okay, so what happened?
So I guess he got dehydrated. Yes.
Okay, now let's see what kind of fluid this patient lost.
What kind of fluid? I think lost from sweating.
Yes. And what about the sodium concentration of the sweat? In the sweat?
Sodium concentration of sweat. Is it 30 to 40 millimole? Yes.
Correct. Very good. Very good. So it's meaning this patient lost hyponatremic solution. So mainly he lost water. So this is why this patient developed hypernatremic hypovolemia. So because sodium reflects the osmolarity, this patient developed a hyperosmolar hypovolemia. Now, because the water distributed the whole compartment, including intracellular and extracellular as well, this is why the water moves from the intracellular space to the extracellular one. And this is why we do have the shrinking of the red blood cells and of course the neuronal cells as well, so the brain cells as well. Now, very importantly, there are at least two types of, let's see, water loss. It can be acute, and this patient possibly has an acute loss of water, or it can lose the water chronically. If we do lose the water chronically, what will happen? The intracellular milieu is going to adjust the osmolarity. It will increase the osmotic activity, meaning that the intracellular milieu, the osmotic particles increases. So it's going to retain the water, all right? That's very, very important. It takes time. So if you're wandering in the desert, that can happen. However, in the summer heat, when you work for 1 hour, there is no way that is going to happen. Why is it so important? Because if you want to normalize the body water or the blood volume in an acute situation, well, it's no problem. If the patient can drink, you can drink mineral water to the patient, or you can infuse the patient. However, what will happen when the situation is chronic? Now, if you want to normalize the blood volume immediately by giving, let's say, and normalize the osmolarity of the fluid, what will happen? Because the intracellular milieu has a higher osmotic activity, now you are loading the patient with more, let's say, hyponatremic solution, and this way brain edema can develop fast. This is why if you have a chronic situation, you should adjust the blood volume 2/3 the first 24 hours and 1/3 in the next 24 hours. So slowly, this is one thing. In other situations, when it's happening acutely, you can restore within 1 day. Another very important one, because the body is going to control the blood volume. That's essential to have the normal blood volume to maintain the normal perfusion in the periphery. So this is why, if, for example, in this situation, this patient lost more water than salt, how we are going to treat this patient, and especially when the patient is unconscious, so patient cannot drink?
Infusion, IV infusion.
What kind of IV infusion you are using?
I will go with
Yeah. No.
I will go with. I wouldn't use the normal saline in this case.
Because the patient lost less sodium, okay? So you don't want to overload the patient with salt, okay? So you want to replace, let's see, the osmolarity of the sodium by using, for example, glucose solution. So you are going to use hyponatremic glucose solution, and this way you can add back the, let's see, the free water to the patient. Well, this hypothesis is very good. However, we do have a problem. What is a problem? You can adjust the osmolarity by giving glucose to the water. That's fine, because 9 grams per liter, that makes, let's say, this is an isotonic solution. However, what will happen when you give this kind of solution to the patient? Okay, you are putting this into the blood, and the glucose uptaken, and the water is going to distribute the whole compartment. So by giving only 1 ml glucose solution, that is going to be distributed to all compartment. So that will increase the blood volume only by 11% or 10%. So this is a slow going process, how you can restore the normal volume. This is why usually they start giving saline or Ringer lactate solution, because this extracellular milieu or a concentration, it goes into extracellular places. So when you give 1 liter of saline, that's going to distribute only in the water and in the interstitial places. So it's meaning 1/3 gets into the blood and 2/3 in the interstitial places. So this way, by using a saline, that's true that you overload the body with a little bit more with the sodium, but you can refill the blood volume faster. And after, okay, by infuse the patient with 2 liters of saline or so, after you can remove, let's say, some sodium and substitute with glucose to normalize the complete blood volume. But because the patient, let's say, recover the consciousness, they can drink. However, if the perfusion is not perfect, patient unconscious, so this is how you want to restore the normal circulation of the patient. Is it understandable? Yes. Okay. Okay. Now, everybody understood this question?
Yes.
On another very important one, if you want to concentrate this, yeah, the sodium increase reflecting the osmolarity very nicely. And if you look at the potassium, doesn't change too much. Doesn't change too much. And the hemoglobin is the upper part, and the hematocrit, it doesn't change. Now, why? First of all, because the water loss affecting only the blood volume by 10% only. So, plus the hematocrit has 2 different opposite changes. One, if you remove the water, so you are going to resuspend the red blood cells in less volume, that's going to increase the hematocrit value, the packed cell volume. However, because the red blood cell is going to shrink, let's be smaller one, you can pack the red blood cell in smaller places. So that's going to decrease the hematocrit. This is why the hematocrit doesn't change too much. Okay, that's another important one. All right. Okay. Ali Reza, it's your turn.
Yes, hello.
Hi. Come on and read the second question.
An elderly person gets sick while enjoying himself on Oktoberfest. He complains of a headache and muscle cramps. He is disoriented. He has drunk 4 liters of beer during the past 2 hours. Physical examination, alcoholic breath, increased plantar extensor reflex.
That's a Babinski sign. That's a Babinski sign. Okay.
Blood pressure is 180 to 100 millimeter of mercury.
Okay.
Laboratory
So that's elevated. All right.
Yes. Laboratory parameters. Serum sodium is low.
All right.
Potassium is normal.
Okay.
And MCV is elevated.
Okay.
The hematocrit is normal, I would say.
All right.
And creatinine is elevated.
Elevated very much.
Urea
And the
is
serum
also
urea as well. Okay.
elevated.
All right. And the urine density, it's normal.
Normal, yes.
Yeah. Okay. Now, let's see what happened with this patient. This patient likes drinking beer. That's great. Now, how much beer you can drink per hour? If you don't like the beer, you can drink water.
1 liter, 2 liters?
Per hour, 1.2 liters per hour. All right? Not more. Because that's meaning that this is the amount of water that the kidney, a normal healthy kidney, can excrete. Now, first of all, this patient double, let's say, the water intake or beer intake. No, that's too much. That could cause an accumulation of the water or the fluid, hyponatremic fluid, all right? What will happen when you overload the body with a hyponatremic fluid? The osmolality of the blood decreases. So every cell has intracellularly higher osmolality, so the water moves intracellular spaces. This is why the MCV is higher one. This is one thing that is higher one. Plus, the sign of brain edema is a plantar extensor reflex, the Babinski sign, when usually the cerebellum, it looks like the decapitated patient, the hernias can happen, for example. Now, the blood pressure can reflect the hypervolemia. Now, what else? This is one thing. Another thing, this patient, I think he had some kidney problem as well, beside of this, let's say, beer overload. How do we know it? Because if the patient would be healthy, what will happen? If you drink more water, you are going to piss more. So you are excreting more water into the urine. So how the urine gravity will change? It's getting close to the water. So it's getting close to the 1,000. But it cannot be 1,000 or cannot be less than 1,000 unless you drink a lot of alcohol. It be about 1,004, 1,003 or so. Now, however, because this is diluted urine or diluted blood, the creatinine should decrease, not increase, because now you let's say, dissolve the creatinine in more volume. That meaning that this patient had a kidney problem prior to this or let's say beer intake. So possible this patient had a chronic kidney failure. Now the last time we had a phrase that we discussed that asteinuria. Can you tell me what is asteinuria, Alizera?
When the kidney cannot dilute or concentrate the urine effectively.
Yes. So meaning that the urine density or the osmolality same as the plasma osmolality. So it means 300 milliosmol. And in our case, this is what happened. So this is an asteinuria, meaning that the patient cannot adjust the osmolality. This is why he developed very fast a hypervolemic and hyponatremic hypervolemia. Now, what would we do with this patient?
You can give mannitol solution.
Which one? What kind of solution?
Mannitol.
Mannitol. Why are you using mannitol solution?
It's an osmotic diuresis. It causes
Okay, so to prevent the brain edema, yes?
Yes.
You want to prevent the brain edema. This is how you start it. And you can use diuretics as well. Possible the kidney can excrete the water. And if not, the patient should be hemodialyzed to remove the excess of the water. Now, this is an acute situation, so there is no problem to, let's see, run over to the extra water. But if it's happening, let's see, chronically, such as, for example, in what is it called, is inappropriate ADH secretion, the syndromes of inappropriate ADH secretion, SIADs, when we do have an elevated ADH, that meaning we do have retention of the water. So that again can cause a hyponatremic hypervolemia. However, that's a chronic situation. So if you do the same, that, okay, let's read over the all excess water, what will happen? Now, because the brain relatively lost the cells, lost the osmotic particles, the opposite can happen. The brain cell will shrink if you normalize, let's see, the osmolality in the extracellular spaces. All right? Any question?
Yes, I have a question. Could you please
Amir?
repeat how the high creatinine explains chronic renal failure?
Okay, let's see. Now, you do have, let's see, in 1 liter, you do have 100 micromole creatinine, okay? Let's assume that this is the normal value. Now, if you start drinking and you are going to dilute the creatinine, for example, by adding an extra 1 liter fluid, that meaning your creatinine concentration should be decreased, yes?
Mm-hmm.
Okay, because this patient having now an elevated hyponatremic hypervolemia, this creatinine should be much higher if you normalize the volume of the blood, yes? So
Yes.
meaning the patient has kidney problem. And because there is no sign that the patient complains of, okay, I don't have urine, anuria or oliguria or anything. So that possible is a chronic problem, not an acute problem. This is why I said this patient possible had a chronic kidney diseases. And especially when we do have asteinuria, asteinuria mostly develops in chronic kidney disease, not an acute kidney disease, because in acute kidney disease, we have anuria. Okay.
Okay.
All right. Amir, you can stay here. Okay, let's read the next question.
Okay. An elderly woman has been on a non-steroidal,
And said, that's fine.
Okay. A treatment for a long time. Okay, wait, I'll read from mine because I can't see in yours. 1 sec. An elderly woman has been on NSAID treatment for a long time because of her rheumatoid arthritis. She felt very weak after having an acute diarrhea. She feels too dizzy and needs to sit down. Physical examination results show decreased skin turgor. Blood pressure in the supine position 120/80 millimeter mercury, standing 90/55 millimeter mercury. Laboratory parameters: the serum sodium is low, 116 millimole per liter. The serum potassium is a little high, 6.2 millimole per liter. The hematocrit is 0.48, which I believe for women is a tiny bit high.
Exactly.
The serum creatinine is 180 micromole per liter, which is quite high. The serum urea is 18 millimole per liter. The urine sodium is 50 millimole per liter. How do you explain the symptoms and the laboratory results?
Okay. Now, so what happened with this patient? This patient has rheumatoid arthritis, okay, and is a painkiller or anti-inflammatory drug. They use NSAID, okay. And now she developed a kidney problem, as you see here. What kind of kidney problem she developed? Let's see. Now, because the kidney losing sodium, all right, never ever you can have higher sodium in the urine than 20 millimole per liter. So it's meaning that this kidney losing sodium plus water. So this is why this patient develop hypovolemia. How do we know that hypovolemia? Because we do have orthostatic hypotension. Okay. And what kind of hypovolemia? Hyponatremic hypovolemia. This is the patient has. Now, what are the problems we have? First of all, this patient has an elevated potassium concentration that is not good. Hyperkalemia is going to cause a arrhythmia, heart arrhythmia. Another thing, creatinine level is high and urea level is high, meaning that the kidney cannot excrete normally the creatinine and urea. That partially can be due to hypovolemia, is true, but is something else beside of this hypovolemia. Now let's see what caused this problem. Normally, what is the effect of NSAID? What is the NSAID effect? Amir?
Yes, the non-steroidal anti-inflammatory drugs.
Yes.
I believe these are like the drugs that inhibit the vitamin K as
No. That's different one. Vitamin K, that's warfarin. NSAID, the painkiller or anti-inflammatory drug.
Cyclooxygenase inhibitor.
Cyclooxygenase inhibitor. So it's going to alter the prostaglandin level. Okay. Now, what are the function of prostaglandins in the kidney?
I believe prostaglandins increase the blood supply to the kidney.
Okay, basically in normal situation, none. So the prostaglandins do not have any effect on the kidney function. However,
yes, mainly when the sympathetic nervous system is activated or the renin-angiotensin-aldosterone system is activated, the vasoconstriction that occurs in the kidney can be so vast that it will result in damage to the kidney.
Yes, almost. So in the case when we do have hypovolemia, to maintain the normal blood flow in the kidney, to maintain the normal renin release, we do need prostaglandins. And these prostaglandins is depending on the COX-2 as well. So this is why the specific COX-2 inhibitor has the same kind of kidney problem. Now, what happened with this patient? Let's see, this patient had a diarrhea, developed an acute hypovolemia. So the prostaglandin should turn on and PGI2 important to release renin, could not happen. What happening? Losing sodium plus the PGE2 that's important to maintain the normal tubular circulation, knocked out. So this patient develop a tubular problem. This is why the patient has an increased creatinine, increased urea, and losing sodium. So this kind of syndrome that develops after administering this NSAID, this is called analgesic nephropathy. Okay? You have to be very careful because due to this analgesic nephropathy, the patient could develop hyperkalemia, and hyperkalemia can cause arrhythmia, and the patient can die. Plus, due to the hypovolemia as well. So this is why when you introduce NSAID to the patient, you have to be very careful and monitor the potassium. Okay. Why is it so important? Because usually the NSAID is taken by elderly patient. An elderly patient, they could have heart problem, heart failure, and heart failure that can cause hyponatremia due to edema, for example, redistribution of the fluid, and this can alter, let's see, the circulating blood volume, and that needs some prostaglandins in the kidney to maintain the normal function. Okay? Question?
Yes. No.
No question. Okay, Astrid, Frida. All right, let's see. Yes.
Okay, so how will the following laboratory values be changed in a protracted, untreated diabetic ketoacidosis?
Yes.
Coma before treatment.
Okay.
Okay, so total potassium of the body, it would decrease, but the extracellular value would increase because the potassium can't enter the cells when there's a insulin deficiency. And the total sodium of the body would also decrease as it would be lost in the urine due to the glucose. And total water fluid of the body would also decrease because we would have polyuria.
So everything what they're asking decreases.
Yeah.
Okay, that's a simple one. You know, everybody wants to a little bit complicate this picture, but if you go to the bathroom and take a leak, you are losing fluid. So your total water content is going to decrease for sure. Because the urine contains sodium, potassium, yeah, your total body potassium and sodium will decrease. Unless you drink, let's say, give back potassium or sodium. But this said, untreated diabetic ketoacidotic coma. Now, what will happen with the serum potassium concentration?
It will increase.
So that's going to change the opposite direction. So the total potassium decreases. Why? The serum potassium will increase. Why?
Because of insulin deficiency, so it can't enter the cells.
Okay, this is partially due to the insulin deficiency and other thing, the excess of the proton, the hydrogen, because hydrogen exchanged by potassium, and this is why the intracellular potassium moves out, and this happening in the kidney as well. So this is why if somebody is suffering of a low pH acidemia, usually that causes hyperkalemia. Alkalemia causes hypokalemia. This is what you should learn it, okay? So if hydrogen up, potassium up. Hydrogen down, potassium down. This is what you have to measure. Now let's see, how do you think the appropriate treatment will change the serum potassium concentration? What is the appropriate treatment of a diabetic ketoacidotic patient? Do you remember?
We should give glucose and insulin.
No. Glucose to a diabetic patient.
Insulin then?
Nope.
No.
First, fluid. Okay. About 3 liters of saline. And after you put insulin into the saline in a mini pump and checking continuously the glucose and the
potassium?
Yes. And if it's needed, you give potassium to the infusion. All right. Do not forget the most important first, to normalize the blood volume, because osmotic diuresis will cause hypernatremic hypovolemia to this patient.
Yeah.
Okay. Nah. All right. Okay. The next one, Fadl.
Yes. Hello.
Hi.
All right.
There.
Okay. An elderly man gets chemotherapy for his chronic lymphoid leukemia, complains of intermittent palpitation, being disoriented, blood pressure is 90/60 millimeters of mercury.
Okay.
The parameters: serum sodium 135, potassium 8.2, hematocrit 0.28. How can you explain the results? What kind of ECG abnormality do you expect to see? Okay, so we know he's an old man. We know he has chemotherapy. We can see the blood pressure is significantly reduced.
Okay.
The sodium serum is it's normal. It's okay. Pretty, yeah. The potassium is increased in the serum, and the hematocrit is decreased. So a decreased hematocrit, that would suggest. And
let's leave him. No, he's old. Yeah, hematocrit is low. He's old.
Oh, okay.
No, by age, the hematocrit is not going to decrease unless you have some problem. And what the patient had, chronic lymphoid leukemia. We will learn that chronic lymphoid leukemia causes the bone marrow infiltration and will decrease the erythropoiesis as well. Okay, so they are going to treat chronic lymphoid leukemia if the patient has or very high number of lymphocytes or lymphadenopathy, that they do have some kind of lymphatic node enlargement, plus if they do have infiltration of the bone marrow, and you can see thrombocytopenia or anemia. So this is how they can start. But what happened? You use chemotherapy, and this chemotherapy blasted the cells, and a lot of potassium gets out.
Yes.
All right.
The serum potassium went
so
up.
hyperkalemia developed, and hyperkalemia caused intermittent palpitation, arrhythmia, all right? Arrhythmia, and this is altered the blood pressure. So the biggest problem right here, hyperkalemia. Now, what kind of ECG abnormalities can you see if the patient has hyperkalemia?
Like increased PR interval and like wide QRS.
Okay, but the first thing that if you will have a tall T wave, symmetric T wave, okay, the 10th T wave. And yes, you do have flattening of the P wave, elongation of the PR, widening of the QRS complex. Yes, this is how it's going.
Yeah.
Yes, can develop ventricular fibrillation, atrial fibrillation, or any kind of arrhythmia. How would you treat this patient? Now, that's very, very important. Which is the biggest problem right now?
The potassium.
Yes, so arrhythmia. So first, you have to prevent the development of arrhythmia. How can you prevent the development of arrhythmia? By giving calcium glucuronate or calcium chloride. That is going to stabilize the sodium channels, okay? And after you can use, here the glucose comes with insulin. Glucose and insulin, because insulin is going to restore, yes, the potassium.
Potassium pump,
Exactly. However, if the patient has this high potassium concentration, this is indication for hemodialysis immediately. But meanwhile, when the patient is taken to the hemodialysis unit, you can use calcium glucuronate and you can use this insulin and glucose solution. Okay? This is what we have to do. Any question?
No.
No. All right. Let's see. Who is the last time Sanjun had the question. Sabine. Hello.
Hi.
Hi. Okay. This is yours.
Okay, so a woman gets hospitalized after having broken several of her bones in a car accident. Blood pressure is 80 to 50 millimeter of mercury, and heart rate is very increased. The patient develops oliguria after being stabilized. And the sodium serum concentration is also increased, and potassium serum concentration is also increased. And the serum creatinine is also increased, and urea is also increased as well. Okay, so I think because the creatinine level is increased a lot, the patient may have like multi-organ failure, including the kidney failure.
We can't hear you, Professor.
You cannot hear me. Oh, again, Jesus Christ, this microphone. Okay, so this patient lost a lot of blood. This is why the redistribution is happened, because less perfusion goes to the kidney, and the kidney doesn't get enough oxygen supply or blood supply. This is why acute kidney failure can develop. The acute kidney failure can be seen by creatinine increases, urea increases, and anuria or oliguria, because they said that's oliguria. Yes?
Yes.
Okay, that's great. Hematocrit decreased, that's due to the blood loss. That's it, nothing else. Now, what would you do with this patient?
Maybe you can give the intravenous mannitol.
Why? Why do you need mannitol?
To increase the urine output?
No.
No.
Now, the problem is here, okay. This, what is saying that after being stabilized, so that's not an acute situation that usually develops maybe 1 day later, all right?
Yep.
So this 1 day, this is why the kidney failure, or you mentioned that multi-organ failure develop. So when in an acute situation happens and the blood pressure decreases below 80 or so, they are going to use noradrenaline or dopamine to, let's say, increase the blood pressure and increase the perfusion of the kidney. But here, the patient already developed an acute kidney failure. So what can we do? First of all, very importantly, because the blood volume and everything is normalized right now with this patient, what you have to do, this acute kidney failure should be treated by hemodialysis. Let's take the patient to the hemodialyzing unit and let stay there for maybe 1 or 2 weeks. And what will happen when you use hemodialysis, the hemodialysis removing the waste products such as the creatinine, urea, and other unmeasured waste product. So this toxic waste material is not going to damage the healthy area of the kidney because some nephron died due to the necrosis, but some nephron is taking over the missing part, so they be hyperfiltrated. So, and the hyperfiltration with the toxic material can damage those healthy parts as well. This is why the hemodialysis can help to survive, let's see, the nephrons, and can help to regain the function of the kidney. And maybe after 2 weeks or so, the kidney regaining the function and the patient can have relatively normal kidney function. Of course, there are some nephrons that destroyed, but it's a very good chance that the patient will survive. Now, however, if the kidney cannot regain the function, only what left, hemodialysis, and finally kidney transplantation. All right?
Okay.
Good. I think these are the questions. There are no more questions. Anybody has any questions?